trophies. Some are loyal soldiers while these other thorns are rosy. Well, thank you, Mike. What a great story. Very inspirational. So before I introduce our next speaker, I just wanted to call out a few items regarding social media and the event today. So you can follow Rock from the Heart on Facebook, Twitter, and LinkedIn. Also, there's a Snapchat actual filter that you can have on your phone to communicate, which is kind of fun this weekend. And then also there's a silent auction taking place. So at each table, there's a QR code that's available that you can use to participate. So just a few things to keep in mind. So our next speaker is Dr. Lola Oluleye, and she's going to be speaking on diseases of the aorta, symptoms and diagnosis. Dr. Oluleye is a cardiologist at Essentia Health Heart and Vascular Center. She obtained her medical degree from the University of Ibadan. Did I pronounce that right, I hope? Thank you, thank you. College of Medicine. She completed her residency in internal medicine at the University of Minnesota Medical School, and she is board certified by the American Board of International or Internal Medicine and Internal Medicine and Cardiovascular Disease. So without further ado, please join me, Dr. Oluleye.
So I'm Dr. Lola. I guess my full name is Lola. Kind of difficult to pronounce for most people, so I go by Lola. But I tell people if you want to sing my name, it's pretty easy. So it's just Lola Oluleye for those that want to try. Okay? Okay, so I'll go straight to the talk. I'll try to make it short and simple. It's a lot of medical jargons, actually. But I'll try to make it as simple as possible. Please try not to fall asleep. If somebody's falling asleep beside you, just tap them so they can wake up and listen to all my torture from what I have to talk about. It's not torture. It's important information to make sure that we reduce risk of heart disease in the population, and that's why we're here. Okay, so usually we have to give a disclosure. I have a research that is presently being funded by the Essentia Health Foundation. Sorry, trying to make sure I don't get confused here. Okay. Just trying to decide where to look. I think I'll just look here so people don't get confused. So my outline, I'll kind of talk about the various aortic heart disease, and then kind of symptoms, general information about each one, and imaging that we do in the department to kind of figure out how to manage the patient, and then we can ask questions at the end. So just kind of in summary, I will basically focus, because this is just a lot of information, but I'll focus mainly on bicuspid aortic valve disease and also aortic aneurysm. But the different type of aortic diseases include bicuspid aortic disease, aortic aneurysm, coarctation of the aorta, which I'll all describe so we don't all get confused, penetrating aortic ulcer, aortic dissection, some form of genetic aortic disease. We also have inflammatory disease such as Takayasu giant cell, and then we have infectious from people having syphilis that gets untreated, and also traumatic aortic injury. Actually, the recent guideline that came out just late last year actually recommend that we start using aortic dilation instead of aortic aneurysm. So just kind of an FYI. So what's bicuspid aortic valve? It's basically, so the normal aortic valve should have like a Mercedes-Benz sign. Oh, I pressed the wrong button. Okay. Can we see the pointer? I don't see it. Oh, it's the small green. Okay. Okay. The normal valve should have like a Mercedes-Benz sign, and that's what you see right here. So this is normal. However, when it's bicuspid, it has just kind of, at times we just have just one line in between. And usually once it opens up, it has like a volleyball sign, which I will kind of show us at some point in one of the pictures. Another type of aortic disease is the coarctation of the aorta. And what does this mean? It just means that there's narrowing in the aorta. So where am I? Okay. So this is the aorta coming out from the left side of the heart. And this is normal. And when it's narrowed, it's kind of like this right here, where you have that black spot where it's a little bit narrow. And patients with this usually, they're usually kind of born with it, so you will catch it, right before their age 20, and they usually have uncontrolled high blood pressure. So usually once we see like young adults with uncontrolled blood pressure, this is something we always have to rule out. And then thoracic aortic dilation. So basically we have different parts of the aorta. So this is the aorta usually coming out from the heart. You have a part called the aortic root, and then another part called the ascending aorta, then that gives blood vessels out to the brain. And we have different portions that can be dilated. You can have just the root get dilated right here. At times you can have just the ascending portion get dilated, and at times you can have both the roots and then the ascending portion get dilated. So aortic dissection, which we've kind of heard a little bit about, basically occurs when you have aortic dilation. So you can just think about a balloon. So when the aorta gets really dilated right here, it just acts like a balloon and it's just gonna pop. If you put too much air in it, it's gonna pop. So it's kind of like the same thing. When it gets too dilated, it's gonna rupture at some point. And when it ruptures, kind of fluid goes into the into the walls and makes it dilate faster and more. And at the end of the day, usually the patient either goes to surgery immediately, and if they don't, it can actually lead to death. And then the other type is called the penetrating aortic ulcer. So I always have to find the pointer here. It's pretty small. Okay, I see it now. So basically, it's kind of like an ulcer as a result of what we call atherosclerotic plaque, and that's just cholesterol and calcium all together, kind of weighing, putting a kind of wear and tear on the vessel, and that definitely just creates an ulcer, and the ulcer can get worse, leading to a dissection if this goes untreated. And kind of going into the genetic types, so basically we have some genetic syndromes that when you see patients come in with this kind of syndromes, you have to worry that they're going to have, aortic dilation that if it's not well treated can definitely lead to aortic dissection. And one of the genetic syndrome is called the Marfan syndrome. And usually it's kind of like a classic presentation. Once you see a patient, you kind of know that that's what they have. Usually they're very tall. Oh, go back. Usually they're very tall, and then they have very long arms and very long legs and actually very short torso. So usually we have to get an echocardiogram in these patients and we have to follow them over time. An echocardiogram is just like a heart ultrasound where we can look at the aorta, and I can show you the pictures later. The other type of genetic syndrome is called the Ehlers-Danlos syndrome. And with these patients, they're very flexible, so they can flex their arm all the way to the back, and they can do all sorts of gymnastics because they're very flexible. However, they have very fragile skin, so basically they get injuries pretty fast. Okay. Okay, right there. So they get injuries really fast. They also develop like scoliosis. So when we see these patients also, we kind of just monitor them with a heart ultrasound to make sure that we're monitoring their aortic dilation, and if they need surgery, we can go ahead sooner rather than later. Also, another type of genetic syndrome is called the Lowitt-Dietz. This is also classic. Once we see them, we know what they have. They have kind of like wide spaced eyes. They have bifid uvula right here. So usually most people have just one. Usually they will have two. They also have like their spine gets a little bit bent and crooked, kind of called scoliosis. At times they are born with a cleft palate, which means that part of their lips and their palate is actually has a defect in there. So they also have the aortic dilation that we have to follow and make sure it does not get worse. So the inflammatory types of aortic disease, we have the giant cell arteritis. So basically, this is mostly common in men, usually in the elderly ages, and it's as a result of inflammation in an artery, actually located at the temple, right here. And usually they have other symptoms. They have headaches, they have visual symptoms, and some inflammatory markers are usually elevated. And with them, you could also have inflammation of the aorta, where they could develop less blood supply to some part of their extremities, and they're also at risk of aortic dilation and also rupture. We also have Takayasu. Arteritis, this is more common actually in females, usually an average age of 40 years, and they are also at risk of the aortic dilation and also narrowing in some portion of the aorta, so which can basically lead to reduction in blood flow to some part of the extremities. They also have inflammation in the vessels supplying the heart muscle, and which can lead to them having heart attacks actually. And the other type, which is an infectious type of aortic disease, is from syphilis infection. And usually if syphilis goes untreated, because some people don't even know they had syphilis, then they can, develop kind of inflammation of the aorta. And usually the infection from syphilis develops with an ulcer, usually within weeks, and then within months they develop rashes on their skin, right? Okay, right. Do you see the pointer? It's so small. Okay. So right here they develop the rashes, and then after about a year or more, it's kind of like a late presentation with syphilis. They develop the aortic disease where it gets dilated. So we see them kind of like a later age if they develop this. We usually just check like a syphilis panel in patients at times with aortic dilation if we find no other reason, just to be sure that that's not the reason why they have that. And then traumatic aortic injury could result from like an accident. And so usually it's just kind of like a pull and push. Just, someone has an accident and then the spine moves, the chest moves also. So that at times could move the aorta in different ways. And that could also lead to rupture of the aorta. And this is usually an emergency. So risk factors include age, greater than 65 years. For those with a younger age group, usually they have like a family history of aortic disease or aortic rupture. So that's usually very important when we get a history or when we see the patients. It's so important that you get a detailed family history. Also, uncontrolled blood pressure, tobacco use, elevated cholesterol level, which would then lead to atherosclerosis, and also genetics, just as we discussed earlier. So just kind of narrowing down to the bicuspid aortic valve and aortic dilation. So basically, bicuspid aortic valve disease is common in 1% of the population. It could be genetic, and it could also be sporadic, so just develop on its own. And usually it could be associated with aortic dilation, and that's why I kind of talk about both of them all at the same time. Could be associated with congenital heart disease, and at times you can find it just as an isolated lesion. So the typical presentation is basically what we see in our clinics, at least in the adult cardiology clinics. It's usually associated with progressive valve dysfunction, diagnosed in kind of like the young/adult population, usually kind of about 50s to 60 years, and usually they need long-term follow-up. Usually these people are at risk of developing infections of their valve. However, they have a normal life expectancy. The other type of bicuspid aortic valve is called the complex type. These are those that are born with other congenital heart disease. One common congenital heart disease is called the Turner syndrome. This is usually, it's mainly in females. Usually they're short and they have like a short neck, usually, and kind of like a wide torso. Usually once we see them, we know that's what they have. And usually you have to screen them immediately because they're at risk of having the bicuspid aortic valve, thoracic aortic dilation, and also the coarctation, which I talked about, which is the narrowing of the aorta. And usually most of these patients have a reduced life expectancy, and usually they require surgery sooner rather than later. And then we also have the undiagnosed. This is pretty rare. I've actually only seen one so far. I saw like an 82-year-old female that was looking at the valve, and I'm like, this is bicuspid. She had no symptoms other than shortness of breath. The valve looked good, other than the fact that it looked bicuspid. So now we had to trace it back for her family members to get screened, because usually if you see a bicuspid aortic valve, family members have to get screened. Kind of like a late presentation, but pretty rare. We can still see it, and they usually will still require surveillance. And so we have different types of aortic dilation also. The most common type is the ascending type. Let's go back again. Okay. The most common type is the ascending, which basically affects the top part of the aorta, the one that basically comes out. And then the less common part is the one that affects the root, just right at the bulbous. I don't know if it's the angle, but for some reason I don't see my pointer.
Want me to point for you?
I've found it. Okay. And then at times it affects the root, which is just right here, and that's 20%. So basically, we have older patients that present with a bicuspid aortic valve. Usually affects either male or females. Usually they develop mostly the aortic stenosis, which means that the valve gets tighter than what it's supposed to be like. And usually once they have aortic dilation, then the dilation affects the ascending part of the aorta, which is what we've been talking about, and basically this part. The younger population that presents with the bicuspid aortic valve, usually at the younger males, and usually their valve is leaky more than it's tight, and usually it affects the root right here when their aorta gets dilated. So try not to bore us with this part. So I'm just gonna walk up here. And just ignore this for now. Sorry. Oh, I need my mic. Okay.
Where you want me to copy to?
You think you can?
Sure.
Okay.
If you want to say upper left corner or first bullet point. You describe it, I'll fade at it.
We'll try to make this work. Okay. So there are different types. We'll make it work.
Okay.
There are different types of the bicuspid aortic valve. The most common is you still see three. So basically, if you remember, I talked about the Mercedes-Benz sign, and it means that there are three leaflets. And with the bicuspid, usually it comes out at two, where two of the leaflets become fused. So right here, we have two of the leaflets are fused right here, and you have that volleyball sign that I talked about earlier. So usually once the valve opens, it opens up as a volleyball sign. And then the other type we have, this is usually just two leaflets, and you could have one leaflet on the left side, another on the right side. And another type you could have is one right at the top and another right at the bottom. And then one of the most common ones that get us confused in clinic also is you see three leaflets, but then it's partially fused. So then we're arguing within ourselves, is this patient a bicuspid aortic valve? Does he have bicuspid aortic valve, or does he have the normal valve? But usually if they're young, like in their 50s, then usually we'll say, okay, it's most likely the partial fusion, because if they have the typical tricuspid, which means three leaflets, they usually less likely present with a tight valve at that age. So for the dilation, when we see patients with aortic dilation, the normal growth that we expect per year is 0.1 to 0.25 centimeters per year. And usually we begin to worry if the aorta is growing faster. So at about 0.5 centimeter per year, usually we'll make indication for surgery. So usually we'll send them to our cardiothoracic surgeon so that they can start following them up closely and then decide on timing of surgery. The other measurements that we look at is if the aorta is greater than 5.5 centimeters, they also made indication for surgery. If it's greater than 5 centimeters and they have either the aortic valve is leaky or the aortic valve is really tight, they also made criteria for surgery. And also if they have genetic syndromes, such as the Marfan syndrome that we talked about, then they made criteria for surgery. And then the other options, like I said, is traumatic aortic injury. That is usually like an emergency and they have to go to surgery immediately. And then the infectious options. So what are kind of like the ways patients will present if they have either an aortic disease or the valve disease? They could present with one, stenosis, which means that the valve, instead of it to be about 1 centimeter in size, all of a sudden becomes about maybe 0.5 centimeters, so it's smaller, and it's not giving them adequate blood supply out. The second most common is that the aorta becomes dilated, and that's what I'm talking about, those two first. And then the third is the valve becomes really leaky, where all the blood that is supposed to go forward into the brain begins to come back into the heart, and that basically just follow. It's kind of like a circuit, so all that blood goes back into the lungs, makes them short of breath, and they become symptomatic. And at times we have other things that we could find, such as the mitral valve prolapse, which means that the other valve on the left side becomes a little bit weak, so you have more valves being affected. And then them developing infection of the valves and also dissection, as we talked about, which is just rupture and a tear in the wall of the aorta. So what are the symptoms we expect? Usually if they have mild to moderate aortic valve disease or the aorta or the dilated aorta, usually they're asymptomatic, and we just kind of follow them kind of like on a yearly basis to make sure that they're doing well, and also to determine the timing of surgery. However, if things get worse, once it becomes severe where the valve is unable to give them adequate blood supply out, then usually they develop chest pain. They have difficulty breathing. They get really dizzy, and at times they can pass out. Because like I said, you're not getting enough blood supply to your brain. So usually you can't get enough to keep going, so people pass out. And once we have a lot of backflow of blood to the wrong place, such as the lungs, at times they also will go to the legs and then cause some leg swelling. So kind of the same thing, but with aortic dilation, the most important thing, especially when someone has aortic dissection, is that they have a sudden tearing chest pain, which almost feels like the worst pain they have ever had. And usually we tell them to make sure that they present immediately if they have that kind of pain, because it means that they meet criteria for surgery immediately. Also, back pain, at times they will have difficulty swallowing, and that's because the aorta is in close proximity to the foot pipe. And once it's dilated, it kind of compresses on the foot pipe, so then they will have difficulty swallowing. If they develop kind of like what we call heart failure, they could have cough and some shortness of breath. And at times when they also have dissection, if the dissection affects the aortic root like I described, sorry I don't have a picture now, but the aortic root, we have the coronaries, the add vessels come out from there, and at times that can get dissected and also cause like a heart attack, and can also cause fluid around the heart. So things kind of can get worse pretty fast. Okay. So diagnostic imaging, like I said, usually we monitor patients at least yearly. We get what we call an echocardiogram, which is an ultrasound of the heart. We get a CT scan also for patients, which uses radiation. We get the MRI, the magnetic resonance imaging, and for some patients that meet criteria, we do the genetic testing for them. So what's the echo? Basically, it's just an ultrasound of the heart. It helps us to decide on the diagnosis of the patient, what kind of bicuspid aortic valve the patient has. Is it already tight? How leaky is it? All those will be answered at that time. Also, we also check how big the aorta is and how far back the aortic dissection gets. If we don't have enough information from the regular heart ultrasound, we actually have a special one that we do called the transesophageal echocardiogram, where we can actually, the patient will be asleep. That's what I tell them, and you will remember anything. But we kind of will go with a probe into the foot pipe where we can take a closer look at the heart to get more pictures, and also will help us figure out if they have any infections. So basically, this is what the ultrasound looks like if they have bicuspid aortic valve, and this is that volleyball sign I was talking about right here. So this is kind of like the aorta coming out from the heart, and then this is the aortic valve right here, open. The other thing is the CT scan / MRI. Usually this is gold standard. And the reason why is with ultrasound, when we scan patients, so we have something called a probe, and the probe has to be tilted up and down to kind of get images. With that, we are able to slice the aorta obliquely rather than straight. So at times we might not get the perfect sizing of the aorta. However, with a CT scan or MRI, we're able to slice in a straight fashion, so then you get a better and a perfect measurement of the aorta. So that's why it's basically the gold standard. It also will give you more information about what the aortic valve defect is. You know, is it tricuspid? Is it fused? Do you have 2 leaflets? Do you have 3 leaflets? It will give you more information. However, usually we try to avoid frequent CT scans in patients less than 50 years just to reduce their radiation exposure. So we might go with MRI initially, and then after 50, then we kind of will focus doing more CT scans. And if once the aorta is greater than 4.5 centimeters, then usually we'll start getting at least yearly CT scans or MRIs. And for CT scan, this is what it looks like also. This is a patient with 2 laterals, 2 kind of like left and right, side by side leaflets. And I don't think you can see it open there. Okay. Okay, I see it now. And then this is the other one with, you know, the anterior and then the posterior leaflets. And then MRI basically looks like this. So we have the leaflet here, it's just an anterior and posterior. And with the valve open, you kind of see that volleyball sign all over again. So basically, what do we normally tell our patients? I think the first thing I tell them is lifestyle changes. A lot of things changes for them, especially if they exercise a lot. And we try to tell them it's okay to do isometric exercise, so which means aerobic form of exercise, exercise that increases your heart rate. However, you have to have restrictions when it comes to isotonic exercise or what we call resistance exercise, or any exercise that has to do with weightlifting. Any exercise that will make you do a lot of grunting usually can acutely increase your blood pressure. And if you have an aortic dilation, then the blood pressure can dilate that aorta pretty faster, and that can get the patient to have a dissection sooner rather than later. We also have a restriction of not lifting more than 50 pounds. This is what has been shown over years, so we always recommend that they do not lift weight more than 50 pounds. The other thing is blood pressure control. 2 medications have been shown to be very beneficial in patients with aortic dilation, and that is medications we call beta blockers, or also angiotensin receptor blockers, or ACE inhibitors. However, other lifestyle changes will include weight loss, dietary changes, which will also affect the cholesterol. With respect to cholesterol, I usually encourage the Mediterranean diet, which basically would include eating more protein and less carbs as much as possible. And that usually helps with weight loss and helps with reducing cholesterol levels too. And in terms of intervention, which I'll leave to the CT surgeons to talk about, and also the interventional cardiologists, we kind of have different options. So we have the minimally invasive surgery, we have the endovascular surgery, the percutaneous aortic valve replacement, which is what most people prefer now, especially those of the elderly population, and we also have the hybrid aortic repair. Questions? I didn't see anybody doze off, so that's good. Yes, please.
I've been told that all of these have some genetic component to them. I had my DNA tested by Johns Hopkins, and they said I don't have any of the 28 genes that predispose you to getting dissections, but the geneticist told me that she feels that they all have some genetic component. What would be your opinion? Will we ever have a day that they discover all the genes that relate to dissection?
I would say at some point they might find the genes. So just like we know that there are more planets out there with them visiting space, I would say it's probably at some point we will. But I would say for now, some of them are genetic and some of them are sporadic, based on risk factors, and we see that a lot. So that's why we focus a lot on risk factors, because we know that those are modifiable. But with genetics, there's not much we can do, but just make sure that we try to reduce, the rate of growth of whatever, either the dilation or the aortic valve disease. When there are less questions, it means that everybody understands all I said. And if anybody remembers or has any questions afterwards, you can always grab me on the side and ask me. Okay. Thank you.